Good morning, everybody. So we will introduce ourselves and then tell you a little bit more about, for the in-person people, the worksheet that they're filling out. All right. There we go. All right, so I'm Jennifer Adrissi, Dr. Adrissi. I'm the founder and program director of the Parkinson's C.O.R.E Collaborative, which I'll tell you more about who we are and what we do later on in the presentation. I'm also a neurologist and a researcher at UCLA.
My name is Jessica Vinegar, and I'm a staff research associate at the Parkinson's C.O.R.E Collaborative and a certified health education specialist.
We are so happy to be here today. This presentation's been a long time in the making, so we just really want to thank ACTS. We want to thank Ms. Sharon and Ms. Jeannie for really answering the call on their lives and inviting us here to share this information. So today we'll be talking about brain health in the Black community and the special highlight on Parkinson's disease. So the people who are here in person received a bit of a worksheet. The reason why we do this short worksheet is one, to just figure out who we're able to impact and who we're talking to as we do these presentations at different organizations, and then also just find ways to improve the presentation because it's always changing. All right, so before we start the presentation, you're really just going to fill out the first page front and back. And then at the end, we'll do the second page front and back. So I think it looks like a lot of you have already started on it. But the first question just asks the age range. You can just give a circle for that. The second question is your gender. Again, circle. For race, you circle which race or races you identify with. Number 4, if you identify as Hispanic or Latino. Let me know if any questions as we go along. I know a lot of you have already finished. The 5th one is, do you personally know anyone with Parkinson's disease? So someone in your family, someone in the church, you know, or a neighbor, something like that. Number 6 was, do you know any famous people with Parkinson's disease? Yes or no? Number 7 is if you've ever participated in clinical research. All right. And on the back of the first page, if you can just jot down a couple words that come to mind when you hear Parkinson's disease. We're going to see how that changes after the presentation. And then there's a few questions, just kind of understanding how much you're aware of Parkinson's disease before the presentation. The first one, it says, we currently have a cure for Parkinson's disease, true or false? You're just going to circle. The next one is, what is not a common symptom of Parkinson's disease? So emphasizing not. So all of the options are common symptoms of Parkinson's disease except for which one? Stiffness, slowness, seizures, or tremor. Which one is not common in Parkinson's disease? The next one is that there are several treatments that can help with the symptoms of Parkinson's disease, true or false? Then number 12, there is a blood test that your doctor can order that can diagnose Parkinson's disease. So they can send you to the lab and send a test. Is that true or false? And then the last question is filling out a research survey or questionnaire. Is that a type of observational research study, or B, an interventional research study? All right, any questions? All right, so we'll go on and jump in and get started. At the end, we do have lunch in the back, so please make sure that you stay for that. And this is also, let us know if questions come up throughout the presentation. We don't want to get too far, you forget your question or we don't address it. So we won't be before you too long, but over the next 40 minutes or so, we'll be learning about one, who's the Parkinson's Core Collaborative? Who are we? We'll go over some basics on brain health in the Black community. We'll do some Parkinson's disease 101. So what is it? What should we be looking out for? What are some of the causes and what's the diagnosis? How's the diagnosis? What are some of the treatments and managements of Parkinson's disease, as well as some research opportunities in Parkinson's disease? And then my favorite part is really the question and answer. So any questions that you didn't ask during the presentation, we can talk towards the end about that as well. So by the end of our presentation, we hope that you'll be able to define and identify contributors to brain health, be able to distinguish between what's just age-related memory loss, mild cognitive impairment, and dementia. What do those different buckets look like? Identify what you can do to increase your brain health. So 5 health promotion strategies, and then understand a little bit more about Parkinson's disease, right? What are the signs? What are the symptoms of it? And what are the risk factors? And then identify the difference between observational and interventional research studies. Hi, so who are we? So we're with the Parkinson's C.O.R.E Collaborative. We started last year, and we really started to address a problem, right? We wanted to make sure that, excuse me, we created a long-term connection with the community to solve a specific issue, which is disparities in Parkinson's disease in our community, okay? So as you know, usually you can input any disease, hypertension, diabetes, Parkinson's, Alzheimer's, and we don't do it as well, right? And so we really want to be part of the solution for that. So we are based on 4 different pillars. So community building, outreach, research, and education. And we're specifically tailored for the Black community. Right, so we're trying to target these specific disparities. So we're trying to do something specific and bring the resources to our communities. All right, I'll pass it over to Jessica.
Okay, thank you so much for getting us started. So as I mentioned earlier, my name is Jessica Vinegar, and we're gonna just jump into brain health, okay? Brain health has been a huge topic lately. What comes to mind when we say the words brain health? You can just raise your hand. What comes to mind? What does it mean to you?
If your brain is healthy or not.
Yeah, brain is healthy. Yeah, functioning. Yes. What about in the back there? Memory, yes, that is huge, right? And in the chat, I can't see, but hopefully we heard that. Okay, they said memory, if our brain is functioning, and yeah, that has a lot to do with it, right? According to the World Health Organization, brain health really means how well we think, we feel, we process emotions, information, how socially connected we are, right? How well we move our bodies and coordinate our bodies so that we're able to live to our full potential, regardless of whether we have disease or not, right? So that's really at the heart of brain health. If our brains are healthy, then we can definitely live our best lives, okay? And our health, which includes brain health, is really determined by our environment, right? Where we live, where we work, where we play, and I'm gonna throw in worship as well, right? That all has an impact in our environment and in our health. So if you look at the image that is behind me, you can see some circles, right? You might be too far to see, but you see interpersonal.
Yeah, the impairment popped up there.
Yes, cognitive impairment, thank you, online. Okay, so yes, interpersonal, community organizations, policies, culture, all that has an effect on our brain health. So for example, at the federal level, right, that's the yellow circle there. Think about food safety regulations, right? That can impact a whole nation. How does that impact our food that we put on our table every single day, right? So that's what I mean about these different categories can really affect our brain health and our health overall. Okay? Now, moving on, and that's actually at the heart of public health, is just knowing the fact that we are impacted by our environment. And what we do at the C.O.R.E Collaborative is we like to bring in the community, right? Work alongside the community, because these are complex issues, right? The community, researchers, and policymakers really have to work together. Okay? All right. So let's get into the brain and heart connection. How many of you knew that there's a connection between brain and heart health? Okay, yeah, some of you did know, right? So there's a lot of lifestyle factors that can impact both our brain health and our heart health. Okay, we're gonna get into that. Okay, lack of physical activity. I know that we hear this all the time, right? Physical activity, moving our bodies, aerobic exercise, right? Something that gets the blood pumping will make your heart more efficient, so it doesn't have to work as hard. Okay, physical activity can also help our brain, right? When we exercise, those endorphins are released into our body, and we have better mental health because of it. Okay, hopefully you guys can still hear me online. Next, we have hypertension, also known as high blood pressure. Yes, thank you so much. High blood pressure. So uncontrolled high blood pressure can actually affect our brain health and our heart health. Okay, and moving on, hearing loss. So this is actually something a lot of people do not know, that there is a connection between brain health and heart health when it comes to hearing loss. So if you are experiencing hearing loss, it is so important to wear our hearing aids. If you're experiencing hearing loss and don't have hearing aids, got to go get that checked out, because that can actually affect cognitive decline later on in life. So we definitely want to get that squared away. Okay? Yes. Yeah. I was just talking about hearing loss and how that has a connection to heart disease and cognitive decline later on in life. Yeah. So definitely have to get that checked out. Do you want to say something more about hearing loss?
Yeah. I know it's something that I think the main thing is the cognitive impairment. As you can imagine, if you can't hear somebody and you're hearing bits and pieces of a conversation, it can be confusing, right? And I know there's a stigma sometimes. People are like, well, I'm not getting I'm not putting no hearing aids in, I'm all right. And it becomes frustrating for the person and their loved ones, right? And so we just put that there just to remind us that, one, it's just kind of aggravating for both parties in the moment, but then over time, it actually can worsen our cognition. And so it's important to make sure that if you are experiencing hearing loss, you get that evaluated and have the treatments or the hearing aids if you need it.
Yes, okay. And diabetes, right? Having diabetes can affect our organs in many different ways, like the kidneys, brain, our heart, and it's also a risk factor for dementia as well, right? Now, in Black and brown communities, there is a higher rate of diabetes, a higher rate of hypertension. Sometimes we can't help it, right? We can do all the things right. We can eat well, we can do physical activity, and still get diabetes, still get hypertension. But the main point that we want to make is managing it, right? Make sure that it's managed and controlled so that we don't have more health issues, okay, coming up for us. Low sleep quality. Okay, how many of y'all believe that we need less sleep as we get older? Yes, so adults, okay, all adults need 7 to 9 hours of sleep per night. Quality. How many of you are getting that? Yeah, okay, good. I'm gonna need to work on that. I'm gonna definitely need to work on that. Okay, but that can affect our heart, can affect our brain. Okay. Smoking. right? So by now, we probably already know that smoking causes a lot of different cancers in our body. But smoking can also affect our cognitive impairment as well, and of course, heart disease. All right, so in a moment, I am going to go over some strategies that we can implement to just promote better brain health. But for now, I did want to get into some of the memory loss, different types of memory loss. Okay, so as we age, it is normal to not remember things as easily as we used to when we were younger. Okay. Yeah, it's not as sharp, right? Like, let me give you an example, right? Not remembering a password, okay, a colleague's name here and there, okay? But usually this has no disruption on your daily life, daily routines, just as normal. You can still learn new information, you can still, process new information, right? Next, is mild cognitive impairment. So it's also known as MCI. Okay, so mild cognitive impairment is a little more significant memory loss. All right, this type of memory loss, friends and family may notice a little more. Okay, but they're still able to complete things on their own. Daily routine is still intact. Okay, able to learn new information. Okay. The third type that we're going to talk about is dementia, and I know some of you have gone to the dementia networking meetings and things like that. So this is significant cognitive impairment. Okay, someone with dementia has severe cognitive and memory changes, and they are unable to care for themselves independently. Okay, so they'll probably need assistance with their finances, running a household, that kind of thing. Okay. All right, so we went over a lot of things. Okay, do I have any questions, first of all? Remember, this is interactive. Yes, please interactive. Feel free to interrupt, ask a question. Okay, so what can we do for better brain health? Okay, one of the things that we can do, quit smoking. Okay, now this is easier said than done. That's just the reality, right? But if someone is ready to quit smoking, there's actually a lot of smoking cessation programs that are available through insurances, through their doctors may have some resources. So you can just call the number on the back of your insurance card and ask for smoking cessation programs. Okay, very good. Diabetes, right? So managing our diabetes is going to be very important. That's the good thing about diabetes, right, is that there's a lot of treatments for it. So you can really manage it and really live a long life with it. It's just getting that under control. Physical activity. So it is recommended that people get 30 minutes of aerobic physical activity. So something that gets the blood pumping 5 days per week. That's for adults. Okay, and that's going to go a long way for brain health, especially Parkinson's, but we'll get more into that. Okay, another one is managing our blood pressure is going to be very, very important. The thing about blood pressure is that you don't know you have it until you go get checked. So please keep those physicals, yearly physicals, so that you're just on top of whether you have hypertension or not. Okay, eat the rainbow. What do I mean? I just mean that eating a well-rounded diet, right? We're talking about lean proteins like fish, like turkey, chicken, and I'm talking about eating all the color of the rainbow in vegetables, okay? But in particular, leafy green vegetables are very, very nutrient dense and great for your brain. All right, and then of course, fiber-rich foods like beans and whole grains are gonna go a long way. All right, so one of the easiest things that we can start doing is walking. Walking can be the first step, right? So I'm talking something as simple as instead of walking your dog for 15 minutes, we're walking our dog for 30. Okay, we're starting a walking group with our friends. We are starting a friendly walking competition. How many steps can you take, right? That's what I'm talking about. Now, I'm also aware that sometimes, it's not safe to walk in our neighborhood, right? That's just the reality. Another option, and it's actually, this is a local options, the Watts Senior Center and the South Los Angeles Sports Activity Center. I called them myself to verify, and they do offer seniors free, fitness classes, okay, on different days. You just have to call, okay? The next option, sometimes when we don't feel comfortable going in person, that's totally fine. We have Senior Planet by AARP, and I'll make sure to drop it in the chat before our, the end of our presentation.
All right, thank you, Jessica. So now we'll get into Parkinson's disease. So who has heard of Parkinson's disease before? Okay, you must have already done a prep for it. Because usually when we come in the community, people really haven't heard too much about it, right? And even if we have heard about it, there's still some confusion. You know, what's Alzheimer's disease versus what's Parkinson's? Are they connected? Are they both dementia? You know, what can we do about it? And so we're gonna get into that, right? Because we can't get treated and feel better if we don't know that we have it. And so this presentation isn't just for you all, but also your loved ones and the people you encounter in life, okay? So what is Parkinson's disease? Parkinson's disease is something we call a neurodegenerative disease or disorder. So as we're all blessed to get older, our brain cells die slowly over time. It comes with the territory, okay? But with people with neurodegenerative disorders, certain brain cells die quicker than they're supposed to. So the most common neurodegenerative disorder is actually Alzheimer's disease. Parkinson's disease is number 2, okay? And so the specific cells that die in the brain are just different in these 2 disorders. So the ones that die quicker than they're supposed to in Parkinson's disease are brain cells that make a special brain chemical called dopamine. So dopamine is responsible for multiple things, but it's really important for the swiftness of our movements, the speed of our movements. It has implications in our gut health, as well as our sleep, and many other things as you see the variety of symptoms that can happen in Parkinson's. And these specific cells live in a part of the brain that we call the basal ganglia, okay? All right. So if you don't take anything else away from this, understand that Parkinson's disease can affect anyone. All right. So one of the main purposes of the Parkinson's C.O.R.E collaborative is really to try to change the face of what Parkinson's disease looks like. Because if you look at a lot of the booklets, right, you may look, some people know Michael J. Fox, you know, sometimes Muhammad Ali. They're like, does this even affect us? Right? Does this even affect women? Answer is yes and yes. Okay. So Parkinson's disease, like I said, is the second most common neurodegenerative disorder. It affects over 10 million people worldwide, and about 90,000 people are diagnosed in the US each year. That number is going to continue to go up as our population continues to age. So it's expected to double actually in the next 50 years. What are some of the risk factors of Parkinson's? The main one is age. So Parkinson's generally is a disorder of older adults. Okay, so most of the people who I manage with Parkinson's are in their 60s, 70s, some in their 50s, but there's also young onset Parkinson's disease. So I have people as young as in their 20s. So young onset is technically if they start having symptoms before the age of 50. We know that the genetics and environment are the main contributors to getting Parkinson's disease. The research right now is really trying to find out more about those specifics. So we know a good number of the genetic mutations that can make people more susceptible than others, but most of these mutations and most of these genetics, we just don't know yet. Okay, so for 90%, so 9 out of every 10 people who have Parkinson's disease, we can't find that gene for them, but we know that it exists. We just have to do some more research to figure that out. Gender, so while Parkinson's disease affects men and women, men are 2 times as likely to get Parkinson's disease, okay? I put an asterisk there because Black people are underrepresented or are diagnosed later and misdiagnosed more. We'll talk about that more, but so are women, right? So we say 2 times more likely for men, but when you account for the amount of women that are probably caring for somebody else, not thinking about themselves, that number of women actually might be higher. And then some less so lifestyle and Parkinson's disease, but that affects it as well. Like head trauma is one. All right, so Parkinson's disease in the Black community. So like I said, while we started the Parkinson's C.O.R.E Collaborative, is to make sure that, one, we increase awareness of Parkinson's disease in our communities, and then we improve our outcomes, right? Because usually you search and you study it and you'll find, and we don't do as well. Not usually because of things that we do or don't do, right? But more systemic issues, systemic racism, things like that. So Black people with Parkinson's disease are less likely to be cared for by a neurologist. So neurologists should be the main people who care for people with Parkinson's, and that's not benign. That has implications because people who are cared for by a neurologist, they end up living longer. They are less likely to have to live in a skilled nursing facility and are able to be more independent for longer. When they did a study looking at just the general community, they saw that Black participants in their study were more likely to associate Parkinson's symptoms with just normal aging. Like, oh, I'm just getting old, right? I'm just getting a little slower, stiffer. I might not be able to do this. And so because of that, they don't tell their doctors about it. Like I said, Black people with Parkinson's disease are more likely to be misdiagnosed or not diagnosed at all. And when they are diagnosed, they're more likely to be at a later stage. So if they've been living with this for, 5, 10 years, and then they can't walk, couldn't work for several years, and now they present to the physician. And like I said, a lot of this isn't just because of us, it's because of the systems, right? Where are the educational workshops like this being done usually? Where are the tools? Where are the neurologists geographically who can do these things? And then Black people with Parkinson's disease are less likely to be on the recommended Parkinson's disease treatments. So that means medications, that means physical therapies. There's non-motor symptoms like mood symptoms. So their depression is less likely to be managed, etc. All right, so what is Parkinson's disease? What does it look like? So Parkinsonism is basically a fancy word for the symptoms that you see in Parkinson's disease. So Parkinson's disease is the most common cause of these group of symptoms called Parkinsonism, okay? So the main thing that has to be there is something that's like slowness. The specific type of slowness we call bradykinesia, but it's basically just slowness. So in people with Parkinson's disease, they tend to just move slower over time. Just kind of the volume was turned down on their voice, but also just like on their movements. Their hand movements are slower. They have more difficulty with dexterity and fine motor movements. Buttons, zippers become more difficult. That's separate from arthritis, which is just common as we get older as well. Stiffness. So there's a stiffness or an increased tone in muscles that we can actually feel on the exam. And then people can actually describe it as well. They're like, this side of my body just feels tight, Sometimes their ankles will turn in when they're not supposed to. Those muscles can be overactivated. People can have cramps, which can actually be painful for some people as well. In their hands, they can get it in their legs, they can get it in their chin. So the specific tremors to kind of be like, maybe this is different from like that family, like the essential tremor that runs in families, is that the tremor in Parkinson's disease is more likely to be a resting tremor. So what that is usually the tremors that you see are worse when people are eating, right? They're writing, And while you can have that in Parkinson's disease, a lot of times they'll also have the tremor, like just when they're sitting, they're watching TV, you see their hand going, or leg tremor. Leg tremor is actually pretty specific for Parkinson's disease. So you see the leg kind of moving when they're sitting. Chin tremor or movement. Other symptoms, motor signs and symptoms of Parkinson's disease, so imbalance, difficulty walking, decreased arm swing, and that has to do with that increased stiffness in the muscles that we talked about. And so you'll see like an asymmetry, right? So people will be walking and one of their arms is not swinging like the other ones. And it's not that they had shoulder surgery or anything, it's just tight on that side, okay? They'll also have like a smaller step with that leg. So while, and I'll talk about this later, so while the symptoms of Parkinson's disease affect both sides, there's usually one side that's more affected. A shuffled walk. And so what that is that people just really don't pick their feet up off the floor. So these are, not really picking up high. They can drag their feet. A lot of times you hear them before that you see them. They're at increased risk of falls because your foot's going to get stuck on a rug or uneven pavement more easily. Muscle cramps, which we talked about, small handwriting, and not only small, but it kind of trails off over time, getting smaller and smaller. So you see this pattern of smaller movement and decrement in Parkinson's disease. A stooped posture, so people will tend to be more hunched over when they're walking as well. There's non-motor signs and symptoms in Parkinson's disease, and depending on the person, sometimes these symptoms can be more debilitating and affect the lives even more than the motor symptoms. One of them is a quiet voice. Excuse me. So the voice just gets softer over time. People are like, can you speak up? Like, what's on? Can you hear it? Speak up? And it's not something that they're doing. It's part on purpose. It's part of the disease. Reduced facial expression, so the face becomes less expressive. And so, it's important for them to know and other people to know, but sometimes people are like, you all right? Like, you look sad or upset or, angry when it's just their face, their muscles don't move as much. Lightheadedness, especially as people change positions, standing up and moving around. That's because in Parkinson's disease, the blood pressure can become a little bit more labile. It'll go up and down sort of when you move around. Sleeping problems, constipation, we talked about dopamine in our gut, the loss of smell or decreased smell. So some of these non-motor symptoms will actually come on, or most of them come on before the motor symptoms. So, people have tremor, end up seeing me, but like, when I think back on it, I have decreased in smell for the past 5 years, right? And so a lot of these actually come first. Depressed mood or anxiety. So people with Parkinson's disease are more likely to have mood symptoms. And so it's making sure that that's addressed. Acting out dreams. That's something that's called REM behavior disorder. So when we sleep, our muscles are supposed to be chill, right? We're supposed to be overall pretty still. And REM behavior disorder, which is associated with Parkinson's disease. Not everyone who has it has Parkinson's, but more than half of people with Parkinson's have REM behavior disorder. If they're fighting or something like that in their dream, they're going to be doing that on the outside as well. So they're at increased risk of falling out of bed. And then thinking and memory changes can also be seen in Parkinson's disease. It's not usually the first thing, so that's something that's different from Alzheimer's and dementias, is that usually it's the other non-motor symptoms and the physical symptoms that you notice first. And then as the disease progresses over several years, you will start noticing some difficulty in memory, things like that. All right, so we talked about some key points of Parkinson's disease. So one, when you've seen one person with Parkinson's, you've seen one Parkinson's. And so people have different combinations of these symptoms. Everybody doesn't even have a tremor, right? And so that makes it confusing because they're like, I'm stiff and slow, and clearly this must because I'm getting older. It might be a little bit more than my friends and my neighbors, but they're not wrong, right? And so, my main thing is, it's okay if it's not Parkinson's disease, but for that kind of light bulb to go off, like something may be off or something may be wrong. Let me at least get this checked out by a neurologist. Symptoms usually start or are worse on one side of the body than the other, and then it changes slow over time. And so that's one thing, nobody wants to have Parkinson's disease. But if there is a silver lining in it, one, your life isn't shortened because of Parkinson's disease. People live about the same length of time. We just want to make sure those years that we're here, you're able to do what you want to do with your loved ones as much as you can, whether that's working, playing, traveling. Just really want to improve the quality of life for people. All right, so gender and racial ethnic differences. We talked already that males are more likely than women to develop Parkinson's disease. Minorities are significantly underdiagnosed, not just Black people, but Hispanics and Asians as well. But Black people are the, most significantly underdiagnosed. And then 1 in 10 people have that early onset or young onset Parkinson's disease, diagnosed before the age of 50. So what causes Parkinson's? We already kind of dabbled in this already. So it's a combination of environmental factors and genetics, okay? In a specific type of combination of the environment and the genetics does it. That's a hand-wavy way to say we don't really know, right? We're using research to really learn more about what are these specific environmental factors. We know some of them. So well water, so people who drink from well water, certain pesticides have been linked to Parkinson's disease, but everybody who drinks well water doesn't get Parkinson's disease, right? So we know that there's a genetic factor as well. How is it diagnosed? So this is another main reason why we're here. So there is no blood test for Parkinson's disease. There's not something that, your primary care doctor says, let me just go ahead and send this in like a diabetes screen, like an A1C. There's not that commercially available right now. We're trying to find something, but it's not. So Parkinson's disease, we use a clinical diagnosis to diagnose someone with Parkinson's disease. What does that mean? It means that you see a neurologist, and through a combination of history and symptoms, so sort of what you're explaining you're living with or you're dealing with, as well as a detailed neurological exam, we're able to make the diagnosis of Parkinson's disease on specific criteria. Okay. Occasionally, other tests will be needed. So there are some medications that can mimic Parkinson's disease, that can look very similar. And so occasionally we'll have to do additional tests. There's also some other more rare neurological disorders that can mimic this. So occasionally we'll need to do additional tests, but oftentimes just by talking to someone and doing a detailed exam, I can make the diagnosis. This scan on the left is what we call a DAT scan. It's done sometimes when we have a question about the diagnosis. Yeah.
You said some medications can mimic symptoms and signs of Parkinson's. What are they prescribed for?
Yeah, no, that's a great question. So there are medications that decrease dopamine, and you can see how that can be mimic Parkinson's disease. Those specific type of medications are usually medications that are antipsychotic medications. And so these are medications that are usually given to people who have psychiatric disorders, rarely just depression or anxiety, but sometimes, all the time, these people will have schizophrenia or schizoaffective disorder or some personality disorders. But there are some of these antipsychotics. So some of the names are risperidone, haloperidol. Haldol is one of them. Yeah, Haldol is actually a high risk of having Parkinson's, the drug associated. Depakote actually can. It's one of the ones that's a little bit less likely, but it can do Parkinson's as well. So it's something to know. But I will also say sometimes, people don't follow the text, but sometimes it's both. So I think that it's just the drug associated, Parkinsonism. But then you see that it's kind of progressing over time, even when people come off the medication. So it doesn't necessarily mean that they also don't have Parkinson's disease. And so I do also manage people who have drug-associated Parkinsonism and follow them over time as well. And that scan basically is a scan where you get an infusion before this sort of MRI-ish scan. And what happens is the substance that they infuse, it binds to the cells that make dopamine and makes them bright. Okay, So you can imagine on the left-hand side of the screen right there, is a huge bright comma. So that person has lots of juicy dopamine cells. On the right side is an abnormal scan, someone who has Parkinson's disease or a Parkinson's disease related disorder. I'm not going to get into sort of the cousins of Parkinson's disease during this this presentation. We can talk about it maybe if I come back. But they will have a smaller bright light, you know, it's almost like little dots or periods instead of a comma, just because they don't have as many dopamine cells. So that can help us in the diagnosis. Yeah.
Is this the same test that's done to diagnose Alzheimer's?
No, it's different. It's different. And so Alzheimer's is a clinical diagnosis, but then they also do a PET scan for different type of dementias to see, you know, the different patterns that they see on the PET scan can give them an idea of what's the different cause of dementia. Dementia should be the overall umbrella, and Alzheimer's being one of the ones under. All right, so who cares for people with Parkinson's disease? Me. So neurologists are doctors who have gone to med school, have sort of your general training, but then have residency in neurology, so the study of the brain and the nervous system. But then movement disorders neurologists like myself have 1 or 2 additional years of training in movement disorders. So Parkinson's disease is the most common movement disorder. There's other cousins, if you will, of Parkinson's disease, some more rare genetic things that I deal with as well, tremor, et cetera. But ideally, if someone can be managed by a movement disorders neurologist, that's ideal, just because they have the most experience with it, and that's where a lot of those resources are held.
Question, is it hereditary?
Yeah, so Parkinson's disease hereditary, that's a great question. So most people with Parkinson's disease, they won't pass it on to their child. And so their child does have a slightly increased risk of Parkinson's disease. So about 1% of people, so 1 out of 100 older people, meaning people over the age of 60, will have Parkinson's disease. So that goes from like 1 to 2% when you have a parent who has Parkinson's disease. That's a great question. Yes.
For your expertise, are you considered a subspecialist?
I am.
Let me repeat our question.
Yeah, thank you. It's a reminder. So the question was, am I considered a subspecialist? So yes, so I'm a neurologist who specializes in movement disorders.
The reason I asked is because I applied, because my mother was diagnosed with dementia and Alzheimer's.
Yeah.
And I wanted to make sure that I was not one of the persons that would have to visit that lane later.
Yeah.
And they told me I was asking for the wrong department.
Yeah.
I had to ask for a subspecialty.
Exactly. So there's different types of subspecialists under neurology. There's probably more than 10 different types. So the one that's for Alzheimer's and associated dementia are our cognitive and behavioral neurologists. Okay, no problem. All right, so it's not just me, I don't work alone. So physical therapists, occupational therapists, speech therapists, as well as social workers. Social workers know all of the things. So I collect social worker friends. They are able to point in the direction of resources that I just can't keep up with. So shout out to the social workers. And we'll go over the other types of therapists on the next slide. Parkinson's disease is treatable. Okay, so we don't have a cure yet for Parkinson's disease. We're working on it with research, but there are many different treatment options, which is why I do what I do, right? And why we're here is because since it is so treatable, when people aren't diagnosed, that's unnecessary suffering. Right? And so we want to make sure that if people do have Parkinson's disease, it's identified and treated. So there's multiple different medications, multiple non-pharmacological therapies such as physical therapy, occupational therapy, et cetera. There's also surgical options for people who have more significant disease.
Question.
Yeah.
The surgical therapy, would that be the shock treatment or the stimulation?
Yeah, that's a great question. So the question was, what are these surgical options? So there's multiple now. The most common one is deep brain stimulation. So it's a surgery that's been around for decades. Essentially, it is brain surgery, but we implant different electrodes in that basal ganglia area that's the most affected. And it has a battery here. We can control it from the outside. And through stimulation, we're able to actually improve symptoms, and it's adjustable over time. There's also a focus ultrasound, which we don't need to get into, but there are multiple surgical options. So that's another reason why it's important if someone does have Parkinson's disease that they're plugged into a movement disorder center, because we want to make sure that those resources are available to them.
All right, thank you. So I'm going to get into some of the therapies, right?
So, my husband has been, diagnosed with vascular dementia, but some of the, symptoms of, Parkinson's, I'm kind of noticing in him. So is it possible to have a combination of Parkinson's and dementia, or they're kind of interrelated, you know?
Yeah, so there's a question here about a family member that's been diagnosed with vascular dementia, but also noticing some of these symptoms that I presented in them. So the vascular dementia is basically, there are different areas in the brain that have been affected because of the blood vessels, and it causes the dementia essentially. Parkinson's disease, how do I explain it? So vascular dementia, people have difficulty with their cognition because of breakdown in brain cells. But the breakdown in brain cells doesn't always follow the textbook, right? Because the vessels are all around the brain. And so it can also have a breakdown in the brain cells that are in the basal ganglia that cause Parkinson's disease. And so you can imagine it's two different types of causes. But in Parkinson's disease, that causes genetic environmental, it's an abnormal protein called alpha-synuclein that makes those brain cells die. And vascular dementia, basically it's due to vascular issues, there's a breakdown in brain cells in multiple areas of the brain. And so yes, sometimes people who have vascular dementia can also have some Parkinsonism, right? That combination of symptoms that we described. Occasionally there is something where there's dementia and Parkinson's-like symptoms, something that's called Lewy body dementia. So Lewy body dementia is basically a brother or sister of Parkinson's disease. It's the same thing, but the only thing is that in Lewy body dementia, the cognitive symptoms come first. So the cognitive symptoms either precede the motor symptoms, or it starts at the same time within that first year. But what's going on in the brain is the same. Okay, so that could also be something. Sometimes people are misdiagnosed into vascular, or they have a combination of things. But if you have questions, kind of talking with your neurologist, they can actually do a specific movement disorders neurological exam to answer that question for you.
And someone being on a Parkinson's medication over years and being misdiagnosed caused them the symptoms later on. So if it was on Parkinson's today for 100 years and then all of a sudden
Gotcha. The question was, if someone was misdiagnosed with Parkinson's, so told that they have Parkinson's and don't actually have it, and they've been on the medication, does that cause harm, basically, to the body and to the brain? And the answer is no. I mean, ideally they haven't had no surgery or nothing for it, but like if they had just like the medication, the main medication for Parkinson's is carbidopa, levodopa. There's other ones as well. It's also called Cinemet. There's also kind of other ones, but that's our mainstay. It doesn't cause long-term issues. It just won't work. Because it's the easiest way for us to give the body that dopamine. And so if that person doesn't have Parkinson's disease or Parkinsonism, so any type of disorder that decreases dopamine, sometimes there's more rare genetic disorders that still decrease dopamine that people actually respond to. But no, there's no long-term issues with it. With that specific medication, it doesn't interfere with other medications, which is good. But I think I'd have to talk specifically to know which medication they were on. But for the most part, it doesn't cause issues or cause breakdown in brain cells.
No, this is great. So yes, like we mentioned earlier, there's a lot of different treatments for Parkinson's, right? And some of them being therapies. So physical therapy. So physical therapists will work with someone with Parkinson's to exaggerate their movements, get big, right? Because people with Parkinson's tend to have slow, small movements. Okay, so it's almost like getting reacclimated with your body again, right? After having Parkinson's. Next is occupational therapy. So occupational therapy really focuses on the fine motor movements and the activities of daily living. So, for example, buttoning a shirt is easy for someone who doesn't have Parkinson's, but imagine having that, right? So they're implementing strategies for that. They also do safety evaluations in your home to prevent falls too. And this is not just for Parkinson's, right? For anybody who has an increased fall risk. All right, and then we have speech therapy as well. Speech therapy is going to focus on increasing your voice volume, articulation, communication, and also help with swallowing as well. Okay?
And just to know, so there's a specific type of physical therapy and speech therapy where the therapists get additional certification for Parkinson's disease. It's called big and loud therapy. So big therapy being the physical therapy component, loud therapy being the speech therapy component. It's also called LSVT. So whenever if someone that you know has Parkinson's disease is referred, ask for someone who has that certification, because that means that they know how to deal with or improve.
What was that again?
LSVT loud.
LSVT certification or big and loud therapy. So sometimes we just need to know what questions to ask, right? And a lot of times we just don't know what questions to ask. And so that'll make sure that you have someone who has experience and expertise.
Okay, so another treatment is exercise. So for Parkinson's disease, exercise is medicine. That's just the reality of it. And exercise will help with balance, agility, strength, confidence in your movements. Mood stabilization helps decrease your falls and increase sense of well-being. And when we're talking about exercise, we want to make sure that we have a mix of different modalities targeting different goals. So for example, aerobic exercise, right? That's going to get the heart pumping and get that dopamine, right? Strength training so that our muscles are strong, right? To prevent falls, and of course, balance. Some of these exercises on the bottom there, they have been studied and they have been effective for Parkinson's disease, like you see Tango, Tai Chi. But honestly, the most important thing is that you find something that you love to do, that you can do consistently, and that's gonna be the best thing, right? Some people like to do the stationary bike. That's a great exercise to do, something that you can stick with.
Yeah. One thing that people really like is called rock steady boxing. So it's a non-contact boxing class that was made for people with Parkinson's disease. It's nice because it's also like a built-in support group, right? People don't want to just sit down and do the support group. They want to do an activity. There was a study that showed that 98% of the people who go to these classes around the country are white. So again, you don't know the questions to ask unless you know the questions to ask. And so rock steady boxing or a non-contact boxing has been shown to be helpful in Parkinson's disease, and people just love it. So
You mentioned a very valuable point. We don't know the questions to ask, and no one gives us those questions to ask. If you don't know the terminology, if you're not involved in the type of experiences that people go through with Alzheimer's and Parkinson's and others, as we age, we will never know. We will never figure it out. Because most physicians don't even ask us. So you don't know what you don't know.
Yeah.
So is there a manifest with a type of question that we can ask of ourselves?
So we don't have them, but that's something that actually we wanted to do, was to create and kind of work with the community advisory committees to find a list of questions to just ask about kind of Parkinson's disease, if you're concerned, like what questions to bring to your doctor, and a lot of times you can fill it out beforehand, right? And send it over to them. Another thing that we do is try to, and we'll get to this later, is about research involvement, like what questions do you even ask about that? To know if you want to, even participate in something.
Okay, let me say one thing.
Yes.
CLA works in partnership with LA County Department of Mental Health. I'm one of their workers. So there, if you want to get those things out, because I work in this community, send it to me.
Yeah.
Will do, done and done. We, for people online, we have a volunteer who's been so gracious to help spread the word, yes.
I just had a comment more than a question. I've been teaching yoga for probably about 25 years, and everything in terms of exercise and Tai Chi is really encompassed in yoga. People don't realize you can get strength training, you can get, full exercise. So that is evidence-based research that's out there that says it does. I've had several people that have come to me as well as some licensed.
We have one of our attendees who's a licensed therapist, a yoga training. That's you. Thank you for doing what you do. I've been trying to do all the things. I'm not the best, but I'm trying. And so all of the benefits of yoga being highlighted here in the room. Okay, sorry.
I just wanted to make a comment on, knowing what to say, because I have a double whammy. My sister also has dementia. And so I'm not her caregiver, but I'm responsible for taking her to her doctor's appointments and, food and stuff like that. So when I take her to her doctor's appointment, they ask her questions, and of course, she doesn't answer correctly. So it's important that, if you go to, to a doctor with your loved one that you're taking care of, that when they answer questions incorrectly, they do correct and explain to the doctor what is really happening with them. So that's very important. I found that.
It's a great comment. I probably should have just given both of you the mic, so that people online could hear the great things being said in the room. But basically saying that there was a double win because she has two family members who have, and just the added need for when you're in the room with the doctors and they're not able to answer some of the questions, they kind of look at you, right? Like, are they taking this medication and this medication? You're like, well, I don't know, right? And so, how can we best equip not only the people living with the disorder, but their family members to have the tools and the information that we needed? Yeah, so we're almost towards the end, but I did want you all to be able to see somebody who has Parkinson's disease. So a lot of times we'll actually bring someone who has Parkinson's with us, so we weren't able today. This person actually has young onset Parkinson's disease. So she's younger and she has more of a tremor flavor to her Parkinson's, but hope that you can hear this. Can you just give a thumbs up, somebody online, when they start playing, let us know you can hear it? Mr. Dixon, can you hear? Thumbs
My
up?
symptoms started, I think, in 2010. I have young onset Parkinson's disease. I got diagnosed in 2016 at the age of 35. I was not happy that I had Parkinson's disease, but I was happy that I finally knew what was going on with me, what was, had been troubling me for almost 6 years, why my hands were shaking, why my muscles were stiff, why I couldn't smell, why I was experiencing anxiety, depression, apathy, all the many different symptoms of Parkinson's. I could then try to figure out a plan to address that one thing as opposed to 20 other different symptoms. So I was ready to strike back. I was ready to fight. I was ready to do whatever was in my power. I have never really looked at it as a negative thing. I genuinely believe that there is opportunity in adversity, opportunity to be stronger, opportunity to be an inspiration to other people. If you're in pain from an illness like this, why not try to utilize that pain and turn it into something positive and turn it into something powerful? I do puzzles, word games. I really enjoy playing Scrabble, just mentally challenging activities like that. I try to exercise as often as possible. I have an indoor bike, which when I get on it, I really do enjoy it. And I love taking walks as well with the dog, with my children, with my husband. When I'm on the bike, I can get to speeds where I definitely forget that I have Parkinson's. Mostly in the evenings when I get to sit with my children and have candid conversations now. And those are really, really special moments. You know, those are the best moments of my day.
All right. So you're able to see someone's story, right? Those are real experts, right? I'm before you, but I asked for training, and I see, people with Parkinson's disease, but the real experts are those who are living with Parkinson's disease and their loved ones, right? And so sometimes it's nice to just hear their story. You can kind of see that she's someone who's younger, right? And so people who are younger get even more barriers that they have to hop over because people don't think about Parkinson's straight away. She has more tremor than somebody else that might have Parkinson's, and so she can kind of see one type of Parkinson's. And then also she's very positive, right? She tries to find the positive, and that might have taken some time. So as you all know, there's stages to things, and so sometimes you just kind of come into terms finding the plan. Eventually, the goal, trying to find the positive and the silver lining, and how you can maximize your years here.
Vision is to try.
Parkinson's does not have dementia, you have a lot of early onset Parkinson's. And she's got the treatment.
Gotcha. So the question was, does Parkinson's disease add to dementia? So Parkinson's disease, as people have it for longer, people do have an increased risk of cognitive impairment. And so, but it's over time. So usually over the first few years, people don't notice too many cognitive issues. Maybe around 5, 6, 7 years or so, people might have what we call mild cognitive impairment, which is they might notice some things are not as sharp. But again, and then, some people with Parkinson's disease will develop dementia, but not all. But what I say is, like, when you've seen one person with Parkinson's, you've seen one person. And so I have people who have had Parkinson's for 10, 20, 30 years and are still traveling, doing what they need to do, independent, with some resources, right? And then I have some people who have more cognitive impairment earlier on. So it just really depends. And really, like she said, like doing the work of keeping the mind going. If they're working, trying to work as long as, fulfills them and that they can work is helpful as well. And just be as active as possible. And that's something that they can do to try to prolong things. Okay. One question: how can we improve our understanding of the ways Parkinson's disease affects our community specifically? One thing is clinical research. So through clinical research, we're able to gain an understanding of Parkinson's disease in underrepresented communities, find ways to eventually slow down and cure the disease. So that's what we're working on, right? That's the, pot at the end of the rainbow, if you will. We want to cure this, right? But the first step towards that is really to find ways to slow down the course of the disease, of what's going on in the brain. So that's what a lot of our research is focused on right now. clinical research can help improve the quality of life, find ways to improve the quality of life for people with Parkinson's, and then develop and improve Parkinson's disease treatment. Yeah.
So the treatments don't slow the progression?
No.
All of the clinical symptoms are still progressing, you're just managing this?
Exactly. So right now, the medications that we have, essentially, if you can think of that dopamine level in the brain going down slowly, but going down slowly over time, we use medications to fill that gap, right? So that our bodies don't feel that deficit of dopamine as much. So it affects the symptoms. It doesn't, what's going on in the brain is going on in the brain. So that's where a lot of our research is right now, is how do we actually start addressing the cause of it. But like I said, the treatments are good. You know, ideally we want something to slow down the course of the disease, but sort of our endpoint that we look at is really quality of life and function. Is what improves a lot with medications right now. That's a great question. All right, disparities in Parkinson's and research participation. So only 6% of Parkinson's disease research participants are from racial and ethnic minorities. Less than 2% are Black people. That's an issue because we're not at that table, figuratively speaking. So what we're learning about Parkinson's disease, the genetics that we're learning about Parkinson's disease are primarily from white people, right? White men, if you want to be more specific. And so we're learning more and more about the people we already know most about and less about us. And so that's another reason why we highlight this during our presentations. Why does this? Because we want to learn how Parkinson's affects our communities specifically, right? The genetics of it, but then also what it looks like. Like we said, Parkinson's disease looks different from person to person and sometimes community to community. So there's certain kind of smaller communities around the world that's like a specifically branded Parkinson's, if you will. And I think that there's a lot that we just don't know. And this is important. Because one, the research discoveries and findings, we want them to apply to us. And then two, like I said, a lot of these treatments and research is becoming tailored. So it's becoming like what we call precision medicine or genetic-based medicine. It's getting fancy. And so we want to make sure that our genes and our samples are part of the pool, right? We want to make sure it's done in an ethical way. So I'm not going to stand before you and act like research hasn't done wrong by us, because it has, right? And it still is in certain areas. But there's certain protections in place. And then learning to ask the right questions, right? If you're presented or you see opportunities for research. There's two different types of research studies. There's observational studies and interventional studies. Observational studies means that nothing's actually being done to you, right? So there's not a medication, an infusion, there's nothing actually being done. They're just learning more about you. So whether that's a survey, questionnaire, right? It could be a blood sample, right? Or maybe they take a MRI to see what one person's brain looks like compared to another. So that's people with Parkinson's disease, but then also we have to see how that compares to people who don't have Parkinson's or controls, as we call them. And so it's important just for representation in these studies. Interventional studies is when they're actually doing something. So this might be a medication. This might be an exercise program, right? Seeing how an exercise program affects our symptoms. But yeah.
Yeah, it looks like she put her hand down.
Sure.
Might have been a mistake.
Okay. So these are just summary slides and we'll wrap up. So some key points for research, so that there's many different opportunities and commitment levels. And so I know sometimes we get approached with research where it's just like, you want to do this infusion that's going to last 6 months and blah, blah, blah. You're like, whoa. What was your name again, right? And so just knowing that there's different levels, you know, it could just be a survey. It could just be, you know, when did your symptoms start and what did it look like? There's opportunities for people who are interested in contributing to research but may not have Parkinson's disease, exercise programs, free exercise programs, which is nice. And also research involvement is always voluntary. It's always optional. And so learning the right, and we can have a follow-up, discussion. This is something that you're interested in, is learning what are those questions to ask to make sure that I'm making an informed decision when somebody approaches me. And knowing that Black people are significantly underrepresented in Parkinson's research and the implications there. There's two great websites if you're like, let me just look for myself. Let me give me a second. Let me just look for what's out there. Clinicaltrials.gov isn't just Parkinson's disease, that's all of the stuff. So that's diabetes, hypertension, that's, obesity studies, some neurological dementia studies, Parkinson's. And you can basically filter it by location, age, disease, and kind of see what clinical trials are out there. I will say, there's a lot there, because if there's a clinical trial, they have to post it on there, and so it can be like drinking from a fire hose type of a thing. And so if there's something that you're interested in, kind of presenting it maybe to your primary care doctor or your neurologist, depending on what type of study it is, would be helpful. That Fox Trial Finder is a website through the Michael J. Fox Foundation, which is specifically for Parkinson's disease studies. So in summary,
in summary. Okay, so yeah, we talked a lot about our lifestyle factors that can impact brain health, right? The hypertension, diabetes, smoking. We also went over the different types of memory loss, right? That memory loss, significant memory loss, is not a normal sign of aging. And we can do something about it, right? We can have behavior changes that can impact both our brain and our heart health.
and then we talked about a lot about Parkinson's disease. It is progressive, but slowly progressive, and there's multiple things that we can do to treat during that time while we work towards a cure. Symptoms are unique to each person, so there's nothing wrong with asking for a referral and you seeing a neurologist, and they're like, actually, no, this doesn't look like Parkinson's disease. Or seeing a movement disorder specialist and say, no, it doesn't, but thanks for coming in, or it's not Parkinson's, but there might be something else, so let me look towards that. So just kind of knowing when there might be something more than just your usual aging. Neurologists or movement disorder specialists are the people who are best equipped to treat Parkinson's disease. We talked about the different types of treatments, medications, and other types of treatments that have been helpful, and just the implications of research in Parkinson's disease. So thank you so much for everything, for being here on a Saturday. I appreciate you. So we'll take questions and comments, but if you could, for those in the room that were able to do the pre-survey, if you can do that second page front and back for us, it just helps us let us know how we did with the presentation, and if there's certain things that we need to highlight, that'd be very helpful. It should probably take only a couple minutes. And then we'll go, and then also while we're waiting, I just wanted to put up our email address, which is parkinsonscore@gmail.com. We are all over the socials. So we are on Instagram, Facebook, and X, formerly known as Twitter. We have some resource guides that we can help pass out as well. So there are Parkinson's disease resource guides, but a lot of the resources in there are just good resources. So I would take that, and then also a lot of the resources are tailored for our community in the guide. Yes, please reach out if you have other organizations that you would like for us to talk with. If you, I'm also here afterwards to talk more. Sometimes people want help navigating the system if they have a question about themselves or a loved one and want to be evaluated. We can talk about different options and try to help navigate that. Yeah, so that's it. We'll leave that up if there's any questions while you fill out that. And then also we have food in the back, so don't forget your food as well. Yes.
Thank you so much for coming. Appreciate you being here. A lot of great nuggets, great takeaways, a lot of information. I know a lot of them have loved ones that have dementia and Parkinson's.
Oh, okay.
I was just saying thank you so much for coming and sharing and just giving us these good nuggets, because we all have family members, loved ones that may have dementia or Parkinson. But I was maybe here, my grandmother has dementia, and I was trying to see the correlation between Parkinson's and dementia, so I learned a lot today. And, so just for clarification, what I understand, with dementia and Parkinson's, the brain cells are dying, I understand. But with Parkinson's, the brain cells that are responsible for the dopamine is what's affected, correct? Are the main ones which affect the motor?
Yeah, which affects the phone as well. Can y'all hear me? Okay.
And then the other one is more cognitive and behavior.
Yeah, so that's a great summary. So yeah, so they're both neurodegenerative disorders. And also dementia. We say kind of dementia in general, but dementia is a umbrella term. You know, those who are in this room probably have heard this already. Alzheimer's being one, vascular dementia, and then otherwise. There's also Parkinson's disease with dementia. So people who develop dementia over time after they have Parkinson's. Lewy body dementia, which is that sibling of Parkinson's disease, which is sort of the cognitive symptoms are that main bit, but then, they actually might be pretty stiff and slow, and I think a troubling tremor now, as well. So yeah, it's really the distribution. And while we put things in buckets, just because it's easier for us to think about, sometimes there's overlap, right? Because those brain cells and where they die, they don't read our textbook. They kind of do what they want. But in order to kind of study things, we group things of what does it look most like. But yeah, that's a good way to summarize it. So Parkinson's disease can have dementia in it, especially if people have had it for longer periods of time, but it's not usually the first thing that they have or the predominant thing.
Right.
Unless it's Lewy body dementia, which is very similar to Parkinson's disease, which is the timing of it is more cognitive initially.
Okay, but Parkinson's is treatable and dementia is not treatable, is that correct?
So, yeah, so there are some medications for Alzheimer's disease or dementias. They don't work as well. We try to use them, and for some people, they notice a little bit, like lamantine, donepezil, and Aricept. Those are some words that you've heard of. But right now, we don't have like great options for dementia, but that's changing. So while I was talking specifically about Parkinson's disease and Parkinson's disease research, there's actually a lot going on in dementia and Alzheimer's disease right now. And looking at, they actually have approved infusion therapies that they think might be able to start slowing down the disease. So it's a certain category of people who qualify for it. So I think things are actually changing. Like in the next decade for dementia, I'm really excited. Parkinson's disease as well, but there's a lot of resources being put towards dementia. And so I think that's also something to keep an eye on. Like I said, the subspecialists for people with dementia are behavioral and cognitive neurologists.
Right, okay, and for the DAT scan versus the PET scan, how often do they have to have those? Because like my grandmother had a PET scan years ago, and I asked for another one, just to kind of see the progression and where she's at and what type, and they keep refusing to give it to her.
Yeah, so it's, unless there's a question, so the question there was how often do you need to have a PET scan? So say that you have a family member with dementia, and you've had the PET scan done several years ago, and want another scan to just see how things are going. Is there a utility or is there, helpfulness in that? And so I'll say usually we don't repeat it unless there's a question of the diagnosis. And it's mostly because when we order a test, we want to see, okay, what are we going to change based on the results, right? And so we did the test, did the scan, and it showed the same thing, no progression. Okay, that's good to know. We did a scan, it showed progression. Okay, that's good to know. But what we're treating is the person and the symptoms and how much their cognition is changing. And so it actually doesn't affect what we do unless there's a question of the cause of the dementia. And so if they're like, maybe 7 years ago, I was pretty sure it was Alzheimer's, but now there's certain things that makes me more concerned for like a frontal temporal dementia or something, or a vascular dementia. Maybe that's the reason why they're like, okay, let me redo the PET scan to see if that distribution is off. Because then we'll manage it and maybe the things that we do might be different based on that. If that makes sense.
Yeah, it makes sense. I think for me, I would just want to know like what kind of treatments or what
Yeah.
medication would be advised. Because it has advanced. From the
Yeah.
time we first got it versus now. And I don't even think it's been a diagnosis of what I think it's Alzheimer's, but
Yeah.
you know.
And that's helpful, right? The type of the dementia. So like I said, I'm trained in general neurology, and so I'm familiar and occasionally treat some Alzheimer's. So like I said, there's only some, there's not a ton right now of medications, but you also want to make sure that you have a diagnosis, and I think they have more, there's more diagnostics and more tests that are available now, the PET scan, and sometimes they do other things as well, like the lumbar puncture. But really being tied into a cognitive center that has those resources and has those insights to know what tests to do, it will be helpful.
So starting with a neurologist, specialized.
Yeah, a neurologist that specializes in cognition. Yeah.
Trying to your statement that you had about you wanted to do an additional test to see how it has progressed. So I too had asked my doctor to do additional testing, and they really didn't want to. And I think basically what they would have asked me to do, and I just kind of wanted to see the progression. But they don't usually want to do a second, scan.
Usually not. I mean, sometimes they will. It really depends on, which neurologist you have and their openness to it. There's sometimes where, I diagnose someone clinically with Parkinson's disease and they're like, I just need to see something. I know it's a clinical diagnosis, but show me something.
Yeah.
And it's like, okay, I ordered the DAT scan. I didn't show what I already said, and so I think it's case by case, but that's usually the reasoning why. Sometimes they don't usually want to do an extra test just because it's not changing anything. But you can always present it and be like, these are the reasons. I know it's not gonna change your management here, but maybe your question is, you said that she has, or she or he has had dementia, but I don't feel like there's a clear understanding of what type of dementia. Can we redo the PET scan and maybe that pattern will give us a better understanding? So one, the management of it, but then two, maybe I'm interested in research and I need to know which check to do, am I doing Alzheimer's? Am I doing frontal temporal? Am I doing, what am I doing here? And so maybe that's the question that you're presenting, that they're like, oh, okay. They understand that, it's not going to change what we do as far as the symptom management, but maybe it has other implications. And maybe you presented that, my loved one, is having some denial, and I understand that this isn't going to change the management. I know that the symptom management is the symptom management, but this will be really helpful just to help, kind of get over that hump, if you will, and makes them more open. So kind of just having the language around that can sometimes be helpful.
And I just wanted to say thank you, and to let you back on Tiffany, the things that she's gonna say. Excellent, excellent, excellent. And I definitely would like to information. I work with the organization called OPICA, program to the community called OPICA Care to support caregivers, and there's no fee. So definitely would like to connect to.
Please do.
Information.
Please do. And if anyone has additional resources, so like I said, we're trying to bring resources, not just educational resources, but tangible resources that are accessible, not super expensive to our communities. And so if we can help share that, not just here, but other places that we go to in the Black communities of LA, and we actually do Zoom too, so we do kind of across the country as well. So that is help.
The resources that we
So-
deal with,
I'm gonna give you my card.
Please.
because we're all over LA County, all of the information in the nonprofits that we deal with is free. We basically do it through Zoom. So, I want the list of all the questions that I have,
Yeah.
so I can share it with the community. We also, especially with them, we're in partnership with you. So we do a lot of senior citizen residencies
Mm-hmm.
and educational programs for the community centers, specialized for the Black community and seniors.
Wonderful. And so more sharing of resources in the room for those who are online. Yeah, so if anyone else wants to sign in here, so we share a lot of resources in person, I'll do that, in person on our social media. We also have a newsletter that we send out, quarterly. Yeah, on the listserv, yes.
Do you have a question?
Yeah.
Oh, yeah. I just wanted to thank you for all of the great information. I think, we have a friend who might have Parkinson's, disease. But, I am currently in California, one of the fellows for Care Generations right now. And I also consider myself a care warrior in my community. But I wanted to mention that I think it's so important to include in all of literature for everyone to get CPR certified. It is so important because I just think about the situation recently with Tito Jackson. He had two people in the car. And if one of those people might have known CPR, maybe they could have helped him before emergency services arrived. So I think since we're boots on the ground caregivers, I'm a caregiver for my 91-year-old mother. But I think to be CPR certified is something that we all need to think about.
Definitely. Like I said, people don't usually die from Parkinson's, right? They die from other stuff. And so it's important for one, we have all our preventative measures, all our other things are being treated, but then also as care partners, I know it's one extra thing to add to do, but very important extra thing, being CPR certified. So, yeah, thank you for adding that.
So I say if you're in the car, someone needs to be CPR certified and in the home.
Thank you for that.
Anything else for the question? Your comments?
It's great to see us teaching us.
Thank you. We're glad to be here. Also, if you or a loved one has Parkinson's disease, so the Parkinson's C.O.R.E, what we're trying to do is create very culturally specific and relevant resources, right? A lot of times we go to these groups and we're the only one, right? And you gotta explain, and you're like, oh God. And so we're having probably starting in the new year, a Black with Parkinson's disease support group. So we have that, and then we'll have additional resources. We're creating so many different partners and resources in the community, physical therapists who want to work with us and do sessions for us. I have a dietitian, she's a chef as well, who wants to do a session with us, for us. And so let us know if you, a loved one, has Parkinson's disease and you want to be looped into that community and updated. It also will come out on our newsletter when new things come up, will be helpful. We're also going to be starting an advisory committee, because we don't want to be the only voices trying to form what the Parkinson's C.O.R.E looks like. And so if that's something that you're interested in, please see us afterwards.
Is there an email or something I can put in the chat for people who want? I did put the C.O.R.E, I put the Parkinson's C.O.R.E, but for the newsletter, do they go there too? Okay, great. Dr. Adrissi, and do you guys mind reintroducing yourself, because the presentation was up when you started, so they couldn't see your face? I'm having a crush on it. I'm like, we got a husband here, very young, knowledgeable. Please, just so they can know who's who.
Yeah, of course. Hi, I'm Jennifer. So I'm Jennifer Adrissi, Dr. Adrissi. I am a movement disorders neurologist. Now we know what that means. And a health services researcher at UCLA, and the founder and director of the Parkinson's C.O.R.E Collaborative, which is trying to create resources by us, for us, to do better by us as well, improve our outcomes in Parkinson's disease as well as brain health. And then this is the amazing Jessica Vinegar.
Hi, yes, I am Jessica Vinegar. I am the staff research associate at the Parkinson's C.O.R.E Collaborative. So thank you so much for hanging with us. We hope that you learned something. One thing that I learned with my professor, if you have knowledge, you have to share it. It's not for you to keep. Please tell somebody. Please, please, please. Okay.
You guys are awesome. We're so grateful for you being here today. Thank you. Thank you for having us. We'll be happy to come back to kind of address other things. I will say I'm not the dementia person, but I can,
Just fine.
yes, thank you to someone. And we also want to thank them at UCLA. They furnished our lunch today. For those of you who are in the room, thank you so much. And they're staying behind if you have questions and you want to talk to them. I'm gonna stop the recording. If there's no more questions in the room or online, are there any more questions?
I am collecting the surveys, please, if you're done. If you haven't signed